Welcome to the Long COVID and Post-Infectious Syndrome ECHO, a collaborative effort between the University of Utah and Bateman Horne Center. I'm Clayton Powers, full-time physical therapist at the University of Utah and also education liaison for Bateman Horne Center. I'm joined by Sarah Day, Project ECHO lead at the University of Utah, and today's session is being recorded, but all participant details or sensitive information will be removed before it's shared on the website or social media. After the session, Sarah will email CME instructions and a copy of the slide deck. Please note that CME credit must be claimed by midnight tonight, and it may take up to 24 hours to appear on your CME profile. We invite you to introduce yourself in the chat and contribute with questions or comments as you feel comfortable. You can raise your hand or unmute yourself to ask a question. We also want to remind everyone that this is a clinician-only forum, so we try to stay professionally focused. Today, we're super privileged to have Dr. Natalie Thomas joining us and presenting to us. She's a research fellow within the Department of Biochemistry and Pharmacology at the University of Melbourne, Australia, who works within the fields of neuroendocrine research and related biomarker studies. And she'll be speaking to us about neuroendocrine dysfunction with long COVID. Dr. Thomas, thank you for being willing to talk to us and wake up so early to be able to share your insights with us. Go ahead and share your slides. The time is yours.
Thank you for that introduction, and thank you so much for the invitation. Yes, it's 4 a.m. Melbourne, Australia time, so I'm very much hoping my brain switches on really quickly for all of us. But I'm really looking forward to sharing some of the work that we've been doing in our lab, what we term systems neuroendocrinology in myalgic encephalomyelitis, chronic fatigue syndrome, and long COVID. So no financial relationships to disclose. So as Clayton said, I'm a research fellow within the Department of Biochemistry and Pharmacology at the University of Melbourne. And I work in the laboratory of Dr. Christopher Armstrong. For those that know Open Medicine Foundation, he is the Melbourne director. And so we have many projects ongoing at the moment, and this is one of them. And my background is actually molecular neuroscience with a strong interest in neuroendocrinology. And that work often leads me to look at sex differences and to look at women's health and the intersect with chronic illness. But I'm also really interested in the broad implications of the neuroendocrine system, how it can affect many physiological systems and have many downstream effects on symptomatology. So very relevant for both males and females in ME/CFS and long COVID. And so with that, I'll move straight into sort of appreciating the audience. I'm not going to tell you what ME/CFS and long COVID is and how we diagnose them and how important it is that we both treat these patients well and research them satisfactorily. We don't conflate the two, but we do find that studying them alongside each other is both really useful and interesting. So one of the reasons that I think both ME/CFS and long COVID can be really difficult to both treat clinically and study can be attributed largely to this heterogeneity of both symptoms. So patients can look really different to one another. They can present really differently. And one patient can look really different from one day to another. So symptoms fluctuate between patients and within patients. There's also building evidence of them being multi-system. So there's evidence of alterations in the immune system, in energy metabolism, in peripheral and central nervous systems and the endocrine system. And also really good evidence to know that these systems have bidirectional crosstalk between each other in both health and disease states. And so it's this loss of homeostasis between these systems, this balance between these systems that are really normally tightly regulated, that have been proposed as central mechanisms in ME/CFS and long COVID. and where one dysfunction in one can propagate into other vulnerable systems. And this potentially is why we're seeing really different and variable symptomatology in different patients. I think it's fair to say currently in terms of the research that we're not seeing one single system failure. And it's very likely we're seeing small changes across systems. And so we really need to think about systems in terms of systems biology, and we really need to think about any measurement gaps, where if we're using just static measurements, we might miss dynamic system level dysfunction. So who is getting ME/CFS and when? So we know that all ages, sex, gender, and race can experience ME/CFS, but we do also know that one of the most credible risk factors of an ME/CFS diagnosis is being female, with approximately a 3-to-1 female predominance. And some of the striking research that I find in the ME/CFS world is this evidence of a bimodal distribution of onset. So we're seeing this bimodal distribution at around late teens, adolescence, and around sort of early midlife, around 40s. And the graph that we can see on the top, this red and blue one, this was a 2014 study by Bakken. You've probably seen it. And this just shows this distribution. And what they showed was the sex disparities starting sort of in that adolescent period. And then they showed that the second peak was only in the females. This was replicated really recently in the last handful of weeks, actually. And a group was really interesting. It was a patient researcher who put out the call on Twitter and really wanted to follow this up. People have been citing this since 2014 as really important. It's never been followed up. And through Twitter, actually got on to the Norwegian ME Association, which had survey data from over 11,000 respondents and said, we've got this data, let's do it. So they looked at the distribution as well. And strikingly, across the 10 European countries that they looked at, they saw really similar distributions. So then again, in that sort of teen group and the later group, sort of being early, mid years. They had more survey data that they could actually phenotype these groups a little bit more. The early peak looked like it was more frequently triggered by infection, vaccination, affected first-degree relatives, and had higher odds of having severe disease as opposed to mild disease. And the second peak was more likely triggered by accident, injury, or surgery, no particular event, or pregnancy and birth. Of course, this could be because of the ages. But to me, this sort of begs the question, is this a structured risk? The risk patterns appear structured and not random. And this is not common, but it's not completely unheard of either, this bimodal distribution, although not at these ages. The closest sort of example would be the autoimmune vitiligo, where we have an early onset sort of before 10 and another one around 30. And they've done some really nice workup where they've shown that this first group is associated with extreme genetic risk. So we don't have the same data, obviously, for long COVID to do exactly the same distribution analysis, but we do have quite good perspective and with high power for long COVID. And what we see is there are some similarities in terms of this, in terms of epidemiology. Again, we see a female predominance across cohorts, around 2-to-1 is the consensus. And in this large study of over 12,000, it showed that the sex differences in long COVID risk was age, pregnancy, and menopause dependent. And we saw the highest risk in females from 40 to 55. Another prospective study with a large cohort looked specifically at pregnancy and followed up 250,000 reproductive aged women with a SARS-CoV-2 infection, and after 90 days showed that if you were pregnant during this infection, you had a lower risk overall of experiencing long COVID. And they looked at trimester as well for the women that were pregnant, and actually showed that the third trimester had the overall reduction in risk of long COVID. We know these trimesters are really different in terms of hormonal milieu and immune remodeling. So I think this is a really important point. And the graph on the right is a smaller study, but they had a pediatric cohort, and they actually showed some sex differences before the age of 5. So males being more higher risk of experiencing long COVID. So this is not just a women's health story, particularly because we have, of course, males and females who experience long COVID and ME/CFS. And also because, these endocrine time points, often you think about puberty and perimenopause, and they've been cited in those studies as potentially the reasons. But this replication showed that these distributions were the same in males and females. And it really made me think, like, what else is happening in these time periods? And some interesting literature from the aging, the aging literature, I thought was quite interesting. And some large-scale data is really showing us that aging isn't linear. That we're actually seeing aging more happened in births in many systems. There's some large-scale metabolic and proteomic studies that show these nonlinear biological shifts with major changes emerging sort of mid-30s to mid-40s. And there's also a study in brain topological networking shifts in sort of, you see it in teenagers, and then again, sort of late 20s, 30s, and again in 60s. And we see this in the immune remodeling as well. And of course, the endocrine function. So quite dramatically in females at puberty, and also that midlife transition, remembering that perimenopause isn't at the average age of 48. That's the end of, that's menopause. Perimenopause starts well earlier. And so it sort of made me think, are these risks emerging when variability increases and resilience decreases in these systems? There is workup on sex differences in both long COVID and ME/CFS, although probably less than you would imagine. There are differences in terms of clinical patterns. So we see higher symptom burden, longer duration in females for ME/CFS, greater comorbidity load in ME/CFS again. We see female-specific triggers, so menstrual cycle, pregnancy, perimenopause has been cited. And in ME/CFS, males have been shown to be more frequently acute infectious onset triggers. When you look through the data as well, cohorts, there are sex differences in the metabolome, proteome, endocrine system, obviously the immune system, and in brain function. And so I always look to that. And there is evidence in lipids, in transcriptomics and microRNA profiles, in steroidomics, something I'll talk a little bit more about, and in immune responses. But it's really understudied. And I think that comes down to that it is a higher diagnosis for both ME/CFS and long COVID to be female, but also females are more likely to participate in research. And so I would say that the male cohort is actually really understudied. Just to very briefly speak about sort of the female-specific conditions in ME/CFS and long COVID. So this is a graph taken from a review study by Beth Pollock and her colleagues that was published in 2023, and they did a great job of collecting the reported data out there. They showed that there were menstrual cycle irregularities, disturbances, sort of bleeding between periods is more likely. Gynepathologies were increased in these cohorts compared to controls, and saw an increase in endometriosis, in non-menstrual pelvic pain, in premenstrual ovarian inefficiencies. We saw pregnancy not only being a potential trigger and moderating the course of the illness, but also instances of pregnancy incidents in the illnesses. And also we see some differences in menopause. So actually seeing premature menopause and earlier menopause in both in ME/CFS and long COVID. And the graph on the right really shows, I think, sort of a lot of the studies to date. A lot of them don't sort of breach this topic, and we have to remember that particularly ME/CFS and long COVID, because it's growing, is very broadly understudied. So when we do have that intersection of women's health and post-infectious illness, which are both historically understudied, it's fair that we're not grappling with data. But the data that does look at this, I think this is a good example of what we're working with. So this was a good study. It showed onset patterns and course of ME/CFS, and did ask questions about female reproductive health. But you can see in this graph, it's quite messy. There's no effect in the blue, improved in yellow, it worsened in red, it's all over the place. But they've asked broadly the menstrual cycles, change your pattern of symptoms, which phase, pregnancy, which trimester, menopause, do they mean menopause when the fluctuations are over, or perimenopause when we actually see variability, and exogenous hormone administration. Are we talking about high dose OCPs that are combined, progesterone onlys, low dose HRT, testosterone? So this is a lot of the older data we're working with here. Some recent evidence really has been a little bit more specific and trying to do a good job of looking at menstrual cycles and long COVID and ME/CFS. And the recent evidence of that was published in Nature Communications last year by Bateman and co-authors showed that there was potential bidirectional relationships between long COVID and menstruation. And in their data set that looked at women with a cycle, in their longitudinal data set of 54, they showed that there was an increased menstrual disturbance in long COVID, that symptom severity does vary across the cycle, and that symptoms peak perimenstrual and in the proliferative phases, so sort of mid-late follicular phase. A preprint on the right here by Victoria Mayall's group, using the Visible app, which you have likely heard of, used longitudinal tracking and tracked over 1,000 menstruating participants. And they also showed that symptoms fluctuate over the menstrual cycle. This is in long COVID and ME/CFS, that crashes were more frequent during menstruation, and that hormonal contraception was associated with fewer crashes and lower symptom burden. So whilst there's not a bucket load of formal evidence out there for female reproductive incidents and ME/CFS and long COVID, there is a bucket load out there on social media and on patient forums. And so this is a bit of a different sort of signal, but I work closely with one of our PhD students. He's a specialist ME/CFS GP and has told me many a times that many of his patients ask for a hormone workup and ask about hormones, and particularly for women, asking about sort of contraceptives and HRT. And so he's grateful for the information that he can, I guess, tell patients that we don't know yet. There are signals and we need to take this really seriously, but there are not beautiful RCTs yet in this space. So as I said, this is not a women's health story at all. We see this in males and females, and I'm really interested in the neuroendocrine system broadly. And this is a really busy slide, and I don't want you to try and sort of look to all the detail at all, although there is a test at the end, but jokes. But this is really just to synthesize over 70 studies across the endocrine system in both ME/CFS and long COVID. And I did it like this rather than look at every axis and every hormone for every study out there. But if we put it together, we can definitely say that I believe there are alterations across all hypothalamus pituitary endocrine axis. There's really broad evidence. I could potentially characterize it as broadly hypofunction, mainly because we're seeing either lower levels or lower activity or no differences, but the findings are really inconsistent. They're really heterogeneous. A lot of these are older studies using older immunoassays. Diagnosis is not stringent for most of these studies. As I said, they're older. All of the levels and activities overlap with controls. This is certainly not a diagnostic biomarker, although of course they're hard to find in ME/CFS and long COVID. And a lot of them aren't replicated, and they're mixed to sex and age. And we know that sex and age have a big, um, uh, uh, they introduce a lot of variability in the data. So the HPA, the hypothalamus pituitary adrenal axis, responsible for cortisol and other sort of stress hormones, although of course we know this is not just a stress hormone, it's so important for energy metabolism, immune system, etc., is probably the most studied, certainly endocrine system in the ME/CFS literature, but potentially one of the most studied biomarkers and systems in ME/CFS just in general. There's a little controversy about that as to why we're studying this system, and if it's just because we want it to be a stress hormone. But again, we know it's not just a stress hormone. But because there's so much data out there, we can combine them, and there has been meta-analysis. And what they have shown is this heterogeneity, so that we're seeing differences in all of these studies. So we may be seeing some altered timing for the HPA axis, so the circadian diurnal fluctuations. I'll speak about that in a little bit more detail in a moment, and potentially some altered feedback sensitivity in studies using low-dose dexamethasone, for example. But really, these meta-analysis tell me that the data out there is just really messy. So one of the meta-analysis was published last week, and the title was Evidence for Bioactive Cortisol Deficiency and Exaggerated Feedback Sensitivity. But that meta-analysis showed heterogeneity of sort of upwards of high 70% to high 90%. It's so variable, and I just don't think I can hang my hat on that until we get some really big studies looking at the dynamics, doing a challenge test, and really thinking about diagnostic criteria and thinking about sex and age. I think we need to do more work to say that really safely. And I would say there's not enough studies in other hormonal systems. So of the studies out there, you'll see one or two, and a lot of them are decreased. So for example, you'll see some that are decreased in DHEA. We have some differences in the thyroid, in THEA and sort of T3 scenarios, a little bit less in your growth hormones, increases in prolactin, but a lot of these are sort of one studies and they haven't been replicated. I would say that across these studies, it's not consistent with endocrine gland failure. But it may be, reflecting central system level dysregulation. And I say that because there is evidence of autoantibodies toward the hypothalamus and the pituitary in ME/CFS. There's some imaging work in both long COVID and ME/CFS looking at the hypothalamus network, and that's showing alterations. And of course, the hypothesis of central brain inflammation. And so I would say that the endocrine system, it's a regulatory system, and small changes can have really large amplified downstream effects with really varied symptomatology. So this is why I think it's really important we study this properly. I think it's the immune system, brain health and energy metabolism is really garnering a lot of research behind it in both these spaces. And I do find, apart from the HPA axis, we're really not doing the work up in the endocrine system in these illnesses enough, I don't think. And importantly, I think some of these systems are modifiable. I think we can actually, look at these axes and see if we can modify them and have moderate these symptoms. And we don't have enough in the toolbox for either of these illnesses yet. So we really need to be thinking about modifiable systems that we have medications for currently. So why are these findings inconsistent? Now, I'll move through the methodology quite quickly. I'm quite chatty and I feel like I'm already over time a little bit, moving toward over time. So I'm going to go through the methods quite quickly, but I do think it explains why we're seeing a bit of a mess in the endocrine system. So we know that hormone biology is dynamic and it's time structured. So here on the left, we can see the sort of the HP axis, and it's governed by largely negative feedback messages. So for example, increasing cortisol will decrease your CRH and your ACTH. We also know they fluctuate across time. So here we have a graph on the right that shows just across sort of a 24-hour period how our hormones fluctuate. We have, I think I've lost a little bit there, but in cortisol is in the orange, and what we see in cortisol is this cortisol awakening response, which is often looked at in research, where upon waking we have a big spike in cortisol and then it decreases throughout the day. So of course, if you're taking a time point, even at 8 p.m., it can look very different than 6 a.m. And very different than 10 a.m. And there's evolutionary reasons for this. It changes our behavior. It changes waking, sleeping, eating, cognition. So hormones are really important for how we feel, how we move through the world. Circulating levels don't, of course, necessarily mean biological activity. So we need to think about bioavailability. So especially in blood work, these hormones are sequestered and they move through the blood with a binding protein. So for example, cortisol has cortisol binding globulins. The sex hormones have sex hormone binding globulins. And without considering these, we don't actually know what's bioactive in the blood work. And interestingly, both cortisol binding globulin and sex hormone binding globulins have been shown to be altered in ME/CFS. We know that that biological activity is it's important to think about tissue access and local metabolism and your enzymes. For example, you've got your 11-beta HSD enzyme, which converts your active cortisol to inactive cortisone. And then, of course, we have to consider receptor density and sensitivity. There has been work in both sorry, maybe it's the 4 a.m. brain, the glucocorticoid receptor and the estrogen receptor beta has been shown to be altered in ME/CFS. But again, a lot of these studies are one-offs and really need to be replicated. And so I guess it's just to think about, a single morning cortisol will not give you a good indication of your HPA function. Random hormone tests may mislead, and timing matters for interpretation, particularly if we're seeing differences in sort of patterns and dynamics, as opposed to major decreases in hormone and loss of function. So I'll move through this quite quickly as well, because the clinical audience will know this well. This won't surprise anyone. But as we move through lifespan trajectories, our sex hormones, all of our hormones actually, but our sex hormones certainly change across time. And so no surprise to anyone in the audience, but we see differences in males and females looking at testosterone and estradiol here on the graph on the left. But what I love to sort of remind ourselves is in males, you often see higher estrone and estradiol levels in males than you would in postmenopausal women. So these sex hormones, I think, are really they're not called the right things. They're so important in much more than reproduction. We Estrogen receptors are found all over the body, and there's lots of different sources of estrogen for both female and male. And they have genomic and non-genomic actions all across the body. And so I think it's really important when I do speak about sex hormones, I'm still considering males and females, because I think estrogens and androgens play a part to this story for both sexes in both ME/CFS and long COVID. When we do look at sex hormones, say estrogen and progesterone in people with menstrual cycles, we have to obviously consider the menstrual cycle. And gold standard practice at the moment is really, in research, is sort of looking at the follicular phase and luteal phase with a confirmed ovulation. Now, clinically, I know that we have more of a protocol looking when we look at estrogen levels or progesterone levels. But again, this is based on sort of self-reported time points of how long our menstrual cycles are, and then a bit of a guesswork as to where we might find high levels of progesterone. And it can be really variable across these different subphases. And so the inconsistent studies may reflect timing issues, not necessarily absence of effect. And this matters from a systems biology perspective. So I've been talking a lot about sex hormones, but of course there's a big so the immune system is a really important system in ME/CFS and long COVID. And one of the most studied systems is the immune system in ME/CFS. And there has been a meta-analysis of natural killer cells, cytotoxicity in ME/CFS, and shown that there is alterations in ME/CFS compared to controls at the meta-analysis level. And we know that natural killer cells express both estrogens and androgen receptors, allowing them to directly respond to sex hormones. And we also know that pregnancy and postpartum periods can change natural killer cell activity. We know that they fluctuate across the menstrual cycle, and they're impacted by hormonal medications like HRT. So we really need to consider this reproductive phase and sex differences and hormonal medications in all the systems that we consider. And this slide really is just to sort of bring it together and sort of remind ourselves that it's a homeostatic integrated network. So the hypothalamus pituitary axis work on each other. They have bidirectional crosstalk that affect each other. And then these axes have impacts on other physiological systems, as I said, the immune system, the brain system, energy metabolism, like mitochondrial function. And this gives really broad clinical manifestations: fatigue, post-exertional malaise, cognitive dysfunction, pain, etc. And so I consider the endocrine system as a central regulator across systems implicated in ME/CFS and long COVID. So I'm not here to suggest that it might initiate all or any cases, but it may act as a homeostatic hub shaping risk, severity, and variability. And if we study them in isolation, the signal might appear weak, but studied as a network, it becomes a lot more coherent. One last method slide, I promise, and it does relate back to studies, is thinking about the measurement of steroid hormones. So steroid hormones look really similar. They all have this 5-ring structure. And so when we use kind of the classic immunoassays, we have a lot of cross-reactivity. They look really similar. So we might be getting cortisol, but we might be getting cortisone. Estradiol is synthesized directly from testosterone, for example. So really, hormones with really different functional impact look really similar structurally. And so some of the more advanced techniques using mass spectrometry allows us to not only be really specific and sensitive with our measurement of steroid hormones, but allows us to look at it within the biosynthesis and metabolism biopathways. So like multi-omic studies, we can do this with steroids, which we've called steroidomics. And there's been 2 studies in ME/CFS that have done this, none that I'm aware of in long COVID yet. So Pipper et al., a Canadian group, used this mass spec technique and found differences in progesterone and in corticosteroid metabolites when they segregated into males and females, and also based on disease severity. On the right is actually some of our workup, and we used a retrospective samples in ME/CFS versus controls. Really good diagnostic criteria, very stringent, and it was sex and age match. But in terms of, it wasn't an endocrine focused study, so they were taken at different time points and different sexes, as I said. And interestingly, what we saw when we did network analysis was that on the figure at C on the bottom is your significant partial correlations in your controls. And we see a really coordinated network, relationships between hormones in controls. And this is completely lost in the ME/CFS cohort. And in fact, D is showing the only significant partial correlation in ME/CFS, and that was between cortisol and cortisone. The Nature Communications publication I showed before, looking at the menstrual cycle and long COVID, actually did some great workup, and this I think is the best available evidence data we have on females and menstrual cycle using these advanced mass spec techniques for measurement. It was a very small group looking at 3 phases, and they showed that 5-alpha dehydrotestosterone, DHT, was increased in long COVID versus controls, and this was phase specific. They only saw this in the secretory, the mid-late luteal phase, and they didn't see any clear differences in estradiol and progesterone. But they did do a lot of self-report and based on sort of timing of your last menstrual period and your cycle length, and confirmed with a progesterone level that suggested ovulation. And so this mid-late luteal phase can be really difficult to capture precisely. And so even small timing shifts based on sort of self-reports, and of course, menstrual cycle can change cycle to cycle, can be really hard to capture this data. And so that brings us to the MELLO protocol from our laboratory. So MELLO, which stands for ME/CFS and long COVID, longitudinal omics workflow. And it has an endocrine and chronobiology sort of focus. And it's essentially where we study those with a menstrual cycle across one cycle and a post-exertional malaise event. And it's an at-home study which allows them to track their sex hormones, so an estrogen and progesterone metabolite, LH and FSH, across the entire cycle every day. So we know exactly where they're at in their menstrual cycle. Because we know exactly where they're at on their menstrual cycle, we have then what we term gold days, where we collect extra biological samples and data. So on these particular days where we're trying to get the max concentration or the minimum concentration or the most stable time period, where we see these in asterisk. So we have it sort of after ovulation, after we see this LH peak, we see it at the height of progesterone levels, We then have another gold day sort of in this when we have a drop in our hormones, and then in the menstrual cycle phase where we see stability in hormones. And so this enables us to look at and in these gold days, we also have a 24-hour urine collection, and we have microblood sampling. So being in biochemistry department and at Bio21, we have access and platforms to many biological assays. And so we plan to use our urine sampling and our blood sampling and our processed PBMCs to really look at these in depth in a systems biology approach. So we look at from multiplex inflammatory cytokine assays to electrolyte measures, steroidomics, as I've spoken about, and then, of course, all of your omics, some transcriptomics workup, and then some immune cell work. And so it's a very early step toward capturing biology in time rather than a single snapshot. But the goal isn't just measurement, it's actually trying to understand variability within individuals. And this can be done with newer sort of technologies. We have sort of your online surveys. You've got microblood sampling that we can do safely now. And then the Myra app on the right is the hormone tracker. And I'll speak about this in a little bit more detail just at the very end, because it's something that patients can use at home. It's available to them now. And of course, an at-home study does confer ecological validity. So they wake up at a normal, natural time. This can reduce stress and PEM, particularly coming into a clinic. So to share some really preliminary data, so it's quite preliminary. So we aim for 20 in each group, ME/CFS, long COVID, and control. We garner our power through it being intensive. So it's almost like an N of 1 type study, but ultimately we want to do this in 60 people. And we'll compare the 3 different groups, and we'll also compare controls to ME/CFS and long COVID. So in terms of recruitment criteria, we use the NICE guidelines for both ME/CFS and long COVID, and then we run DSQ2 surveys. So very preliminary results. They look similar, the groups, in terms of age and BMI, and we have, in terms of symptom burden, from mild to quite severe patients within our cohorts currently that we've analysed so far. And what we're seeing here is the real-time hormone data. So the data that we have, we obviously don't have any biological assays completed yet. And we've used this to standardize sample timing by looking at relative day to LH peak. And this is splined work. So on the left, we have raw hormone levels. And on the right is statistically how we've looked at sort of the dynamics between the groups. So we've used baseline corrected splines and generalized additive models. We're using an autocorrelation. And what we see is differences with a group and time effect for both an estrogen metabolite in the urine, a progesterone metabolite in the urine, and a ratio between the two. And just observing the data, it looks like we're sort of seeing reduced estrogen bump at that ovulatory period, and not as high and sustained progesterone increases in the patient cohort. And just looking at the 2 time points, of course, this isn't a large study in terms of 1 time point, but we didn't see differences in estrogens or progesterones. So I think this just goes to show that I think we need to consider dynamics as well. And so to wrap up, so in terms of the signal, I think we have subtle dysregulation, not necessarily stark deficiencies in any of the endocrine systems, but we do see it across HPA, GT, and S-axes. But they're context-dependent effects where we really need to consider timing and biological states. I've gone through the methodology in terms of why I think the literature is inconsistent. So whilst we shouldn't throw away this research, and while we should just do a better job of it if we can, and what's emerging. So again, this multi-axis involvement where not only do we need to consider the endocrine function, but we need to consider that in a larger systems biology format. Potentially, we need to consider this being downstream of central dysfunction. The idea of vulnerability peaks, so these two peaks in both sexes really obviously intrigues me. And then just really thinking about these hypothalamus pituitary gonadal signals, so cycle-linked symptoms, pregnancy, luteal phase effects, and considering if this is a modifiable factor. And of course, that we need to do more research in the male population. I think there's a phenotyping gap there. So the take home is that I don't think it's a large system failure, but I do think we're seeing dysregulation. And we must remember that small shifts in a master regulator like the endocrine system can propagate across systems, and that the endocrine function may shape risk, severity, variability, and is modified. So what's next for research? Time-resolved methodology, which I've gone through. I think we need to stratify by sex, illness onset, and reproductive phase. Menstrual cycle phases are difficult unless it's your prime research question, but I think we can do better asking about reproductive phase. We can then look at trials, particularly RCTs, looking at hormones and recruit by hormone phenotype by using your tracking of hormones and seeing where people are at. And I think we need to prioritize clinical outcomes like PEM, function, and cognition. There are candidate therapies. So using existing hormonal therapies, there are no nice RCTs for you today. And unfortunately, we're working toward it. And things to be considered are HRT, your oral contraceptive pill, testosterone, SERMs. So if it turns out, for example, that estrogens are good at modifying symptoms, we can use things like selective estrogen receptor modulators in males that don't have feminizing effects, just works in things like the brain and the bone, and other formulations like tibolone. And it may be a safer sort of reversible entry point. And we need to, in these RCTs, think about treatment response biomarkers, what's going on. So the priority replication study is the ME/CFS estrogen progesterone study that showed that in women, there was a response, hasn't been formally retested in 30 years. And I think the estrogen receptor density requires replication too. So what can we do now? I think I'm preaching to the choir with this audience, but listen to our patients. Cycle-linked symptoms can be really informative. We can ask about cycle phases, reproductive stages, hormonal exposures, and we can track things at home and provide extra information for our clinicians if it's not too taxing on patients, of course. So the Visible app, which I'm sure you've all heard of, and then the Myra hormone device. If people really do think that their menstrual cycle is changing their symptoms or inducing PEM, there are ways that you can track that. And watch for comorbidity patterns. We know endometriosis, PCOS are overrepresented. And so, to close, this work is still early. I don't have nice RCTs for you. I'm sorry, in the field. It's emerging biology, but there is a consistent pattern across epidemiology and patient reports and biology, which really suggests a consistent pattern that means we should really be working up this area far more. And it may not be a question of deficiency, but of timing and regulation within a dynamic system. And from a research perspective, it suggests that we need to start measuring biology in time and not at just a single time point, because we may be missing the biology. So I'll leave it there. And I'm very happy to take any questions from the team here. And again, I hope my brain will wake up for you for the questions.
Thank you so much, Dr. Thomas. That was great. That was, yeah, thank you for waking up early as well. Any questions from our those joining or our mentors? Yeah, Dr. Brown.
Yeah, it's really a great summary and also interesting work that you've worked on. And I like your study design, I find really interesting. And hopefully will be really enlightening as it's sort of following people through time as opposed to, and using them as their own control as opposed to just snapshots, which as an ICU doctor, I look at a lot of random cortisols and it's like, what do you make of that stuff? It's really hard. I do know because on the Recover, the US big national trial and NIH trial. I'm on the pathobiology committee, and I do know that there is going to be some metabolomics and proteomics stuff coming out that will be very relevant to you. I can't tell you exactly why yet, but um, I think you'll be very interested. But I think that will help us clue into some of these things because I don't think it's just going to be as simple as, oh, there's a blood test and this is low and we supplement it. I think there's a lot of um metabolic dysfunction and things like that, but at least it will clue us into which pathways are weird and like, being able to understand that better. But it'll be interesting. Very
Yeah, absolutely. That was a bit of a tease. I really want to know the the
sorry.
results.
I was like, I'm not allowed to say, but let's just say the signals are better than I thought they would be.
Wow, that's incredible. And I think it's you know, technologies like sort of us being able to do multi-omics to really think about it in a systems perspective and use the line that I normally use, which I don't think I did this morning, but it was that the mellow protocol is that people that are using themselves as controls,
Mhm.
which I think is really critical as well. I think we need very large sample sizes if we're using cross-sectional. And I think repeated measures is the way forward. It was actually why I was recruited over because of my geeky love of study design and repeated measures. And brought over that neuroendocrine world just because it was my background and realized it was implicated and we probably should follow that up too. But yeah, the repeated measures, multi-omics, I think that's where we're going to see our signals for both long COVID and ME/CFS.
I think, with long COVID in some ways, I think it's sort of like the giant natural experiment, that we did all together with COVID. But I think it's going to really highlight how a lot of these things actually function that we have never really understood very well. But I think it's going to be fascinating. My hope is that it'll translate into things that we can follow, especially with some of these studies. We also do have the pregnancy cohort too as part of Recover. I'm not sure from a proteomics, metabolomics component what they're doing, if they're doing stuff with those samples. But again, would sort of be interesting looking at that population that was pregnant and then post-pregnancy as well. So could be additional sources of data too once they start publishing that as well.
Yeah, absolutely. And tell them to consider steroidomics.
Any other questions or comments?
I have one. This is Dr. Bell in Salt Lake. Can you hear me okay?
Yes.
I yeah.
Does the long COVID clinic still exist at the University of Utah, Jeanette? I
Oh,
guess the
we're
question's for you.
still here, still plugging along, still getting a lot of referrals. Our state funding ends in December, but we are not going anywhere after that. I know there was some rumors of our demise that were overstated. No, we have actually, if anything, our referrals have been steady and the university is still doing its thing. So we're here.
Yeah, thank you.
Just reading some of the chat messages as well. Thank you for all the messages in there.
Yes, Anne had, oh, go ahead, Dr. Bateman.
I don't really have a question. I just want to thank Natalie so much. It's a humbling reminder of how little we know, right? But it's so easy to try to simplify things for the sake of time or whatever, but it's not a reality, right? About 10 years ago, I when I was reading for the IOM criteria for for ME/CFS, I was doing the neuroendocrines research as part of my, and I was struck by how little we can do as clinicians, right, to actually study most of these systems. But it was valuable information, and I really like talking to my patients about as much as possible too, because they don't understand the complexities. But showing them those curves through the month and things like that have been really good teaching tools. So, but thank you for the reminder, and also about methodology, super important.
Thank you for saying that. I'm very aware it's a clinical research group, group, and was sort of battering on about methodology there. But I'm glad you appreciated it, because I think that's where we're at in terms of the neuroendocrine system in ME/CFS and long COVID. And I would be amiss not to talk about it, because I think that's where our problems and our answers lie for this system. So thank you for sharing that.
So much work ahead still, right?
Yes, absolutely. Onwards and upwards. We'll do it.
And then can you touch on methodology, since that was one of the comments in the chat, is how one of the questions I have is translating research into clinical practice, because it seems to take so long to change clinical practice. So as we have new updates in research, how do we disseminate that and help clinicians to start using that information or staying up to date on it? Any thoughts?
Your forums like this, if I had beautiful RCTs, I would have been sharing that, and then the clinicians could have taken that information. I think the reminder is that it's likely implicated. It's important to listen to patients, which I know I'm preaching to the choir in this group. But utilizing the the tools that you already have is important, and the message here for the endocrine system. But I think forums like this, and obviously clinicians are very time poor and busy, but conferences and yeah, that's, I guess, from my end what I would suggest for, yeah, translation. And I think it's researchers' jobs as well to kind of get ourselves out there a bit more. We're quite good at hiding away in laboratories. Um, so I think it's our job to share. And I don't have beautiful RCTs to share. And I thought, well, I'm always harping on to the people around me about how important this is. So maybe I can just harp on to the clinicians and share what we do know. And so that was my, yeah, me being brave and trying to share what we do know, which is not clean yet.
No, but so helpful. And thank you. Thank you again for waking up early and presenting to us. And thank you everyone who joined today. Don't forget to claim CME credit for attending. And our next session will be on emerging long COVID research with Beth Pollock, who actually was the one who suggested that I reach out to you and help or have you come join us. So I'm grateful to her for that.